So thank you everyone for coming to listen to my talk tonight on trauma in mountain biking. So this presentation of mine started a few years ago as the mountain biking boom in Tassie just took off. We suddenly had this massive influx of mountain bike trauma hitting our emergency department, and we had a lot of clinicians who really didn't understand the mechanism of injury of what was actually happening with these patients that were presenting. So our doctors, surgeons, etc. were happy for me to put this together just to help increase people's understanding of mountain bike trauma and some of the injuries that you might expect or just to look out for. So the picture that you see up on the screen is my trusty little steed at one of the mountain bike parks in Tasmania called Medina. Does anyone but come to Tassie to mountain bike? Yep, yeah, yeah. There's a few in the room. Good. So that's one of the. So basically, the objectives of tonight's presentation: just improve knowledge of the mechanisms of injury associated with mountain bike trauma, some improved knowledge of the types of injuries, and some questions to ask if a patient presents post a mountain bike trauma related injury. So in Tasmania, and like the rest of Australia, the number of mountain bike parks, trails to ride has just increased exponentially over the last 10 plus years. So this map, all the little red dots show the mountain biking trails around Tasmania. So there's quite a few up north, there's a few emerging down the west coast of Tasmania, and then down south there is also quite a lot as well. There's also a little one just to the, probably to the bottom, sort of standing on its own, which is Medina Mountain Bike Park. So that's the biggest gravity mountain bike park in the Southern Hemisphere. Of which I'm also lucky enough to do some work there in Pro Patrol. So basically ski patrol, but on mountain bikes. And we have seen a huge increase in injuries as the number of riders coming to Tasmania has grown over the years. So part of the issue with mountain bike trauma in Tasmania is to do with the logistics. So often, as you could see from the map before, there's the geographical location of the accident and where it's occurred, and then thinking about where the nearest treatment facility is. So you've got a huge amount of our population in the north of the state, but our aeromedical service is based in Hobart in the south of the state. And when I first started this presentation, we actually only had one helicopter. And then we had the fixed wing as well. So over the last couple of years, we have actually obtained a second helicopter, thanks to Victoria. And yeah, we've also still got the RFDS run our fixed wing service as well. So the geographical location of accidents in Tassie proves quite a lot of issues in terms of the weather, also available phone reception in the area, distances to treatment facilities from where people crash, where the aircraft or ambulances can actually get to, ambulance TAS availability, because half the time they're either ramped at the General or the Royal. The retrieval helicopter might actually be on King Island, Flinders Island, or taking someone to the Alfred or the Austin. And just weather conditions of Tasmania in general. So just some other considerations. So riders are often travelling at some fairly high speeds, more than 30 kilometres an hour for your average Joe Blow, but some of our pro riders can be hitting speeds of above 50 k's an hour, going down some pretty hectic trails. Often the degree of impact, lower speed crashes can actually still result in some pretty significant injuries. some of the terrain, which hopefully if the video works tonight, you'll see some of the terrain that riders are actually riding down. And then we often have riders attempting features that exceed their own abilities. And this is usually groups of men, interstate visitors, not looking at anyone in particular. And so depending on where people are riding, the time of year that they're riding, the trails that they're riding, people might not actually be wearing as much protective clothing as they should be or could be, especially if they've got long climbs before they've got long descents. You're not going to be wearing a chest protector, a full face helmet, goggles, knee pads, elbow pads if you've got, you know, a 15-kilometre climb to the top of trails before you descend them. So that can also be a little bit of an issue as well. So I've got here, and I'm praying that it works, a bit of a video that's all of friends, family and their children have sent me of local riders and some of the accidents that happen. Yep, I think I'm on. I apologise if there's any little swear words.
You! Yeah!
Woo! Yep.
Hold it! Yeah! Put it down! What happened?
You good?
Take two.
Take two. Let's go.
Let's go. Are you good?
Okay, let's go. Fuck.
So as you can see, that's quite a wide variety of accidents. So at the start we had when it's going quite well, and the videos that we've shared are generally friends, family and our work colleagues and what they've just sent to me last week. And so these are the accidents that are the jumps. These are jumps that kids are building in their backyards, and these are the trails that our friends and family are riding every day. So just if anyone wants to watch this one again, So this is actually this is a trail at Maydena Bike Park called Zen Garden. So it's a pro trail. And yeah, you really don't want to ride this trail unless you really know what you're doing. I think on this day the guy hesitated a little bit too much. But just to look at how steep this is.
Fuck! Shit.
Oops. Sorry. Did say that there was a couple of swear words. That was my disclaimer. And so this was the that was the aftermath. So that was a significant head injury. I think he had bilateral wrists, which were probably the least of his worries. There was multiple spinal fractures, bilateral pneumothoraces, and yeah, a myriad of other issues from that. So from a lot of mountain bike trauma, there's some of the common injuries that we can probably expect to see. Clavicle fractures from sort of rolling over the handlebars. We get a lot of shoulder injuries, a lot of distal radial fractures, rib fractures, skin abrasions and wounds, and some minor head injuries. Some of our less common injuries that we might see and do see: neck and spinal fractures, major head injuries, snake bites, abdominal injuries, chest injuries, and some major long bone fractures. So I've just popped a couple of pictures here. So the picture on my left, you're right, is actually us doing patrol training at the bike park, where we've actually got every rider that registers and signs a waiver to ride, they get the number for the accident and emergency phone that they must wear on their wrist. So if someone was to crash, they need assistance, the person, actually a rider, someone next, hopefully who finds them, can ring the number to say, hello, such and such has crashed. We try and get the information of the trail, the details, then we send one of our patrollers out to go and assess them, and then we can call through for the equipment that we might need to extricate the rider. So this is us just having a bit of a practice of our gear, bits and pieces. So we've got a mule, stretcher, a scoop, and hypo wraps, etc. So I've just got a couple of case studies to talk through about some patients that I've come across over the last few years, and just have a talk about some of the issues that we came across with these patients. So the first case study is a 31-year-old male. His triage was written as, at midday, approximately 20 kilometres an hour, he came off over the handlebars, posted jump, nil LOC, helmet worn, landed on the left side and head, forehead grazing, altered sensation in both forearms. He walked 4 kilometres post the accident, given 20 milligrams of IV more, 50 marks of IV fentanyl, and some penthrone. He was given a category 2 in ED. He was seen by an ED registrar, had a full primary survey performed, and full spinal precautions were in place. He had blood, CT brain, C-spine chest were requested. He had a significant amount of IV analgesia and antiemetics for the ongoing pain and altered sensation in both of his arms. He also had a subsequent MRI requested by ED, and that report showed that there was some significant C5, C6 disc protrusion leading to the severe spinal canal narrowing. So this patient remained in ED and then subsequently our emergency medical unit for 24 hours before being admitted to a surgical ward and then being transferred down to the Royal Hobart, which is where our neuro ward is. The neuro ward then performed an anterior cervical discectomy and fusion, which relieved the pressure on his spinal cord and immediate improvement on his symptoms. And then after a period of rehabilitation, he has of course returned to riding his mountain bike. So just some issues that arose with this presentation. He actually crashed in the blue tier. So for anyone who knows Derby, Who Knows Tasmania. Derby's one of our main mountain biking hubs. You've also then from there, you can travel another probably 40 minutes up into the Blue Tier where there's an amazing wilderness trail. He crashed in there. There was no phone reception, so that's why he and his mate had to walk 4 kilometres to get to phone reception and to get help. By the time he got to our hospital, he'd had a CT report and this showed that there was no spinal fractures. We had a locum doctor at the time who discussed it with the on-call, and based on the CT being clear, they were actually going to discharge this patient home. I stepped in at that point and got one of our ED registrars to come back in and put their foot down because the patient also lived at Derby, an hour and a half out of town. He was still requiring morphine, irretractable nausea and vomiting, and basically had a spinal injury. So there was also some delays in getting to the Royal Hobart Hospital just due to access block. So that was that one. So the second case study that I'll talk about is a 21-year-old male. He reported that he clipped a loose rock called a doll's head while he was riding his bike down a trail at speed. Passing off-duty bike patrol and another friend stopped to render assistance after the crash, and he and his mate were adamant that, yep, he's fine. They wanted to keep riding. We politely asked them to just stay put for a minute just so we could actually do a proper primary survey. We then moved on to secondary survey. Em said, mate, you did actually say that you've hurt your leg. Can you just drop your DAX? So, which he obligingly did, and we found on his inner thigh a huge hematoma developing, which he hadn't actually realised. So we thought, well, that's actually most likely secondary to his handlebar impacting his thigh. Once he realised that he had a hematoma the size of a doll's head growing in his thigh, he started to feel quite unwell, had a near vasovagal, which we laid him down. That actually gave us time to call bike patrol, who were actually on duty, who then got our troopy and drove probably 30 minutes up the hill to come and assess him and help us extricate him. During that time, he was actually able to recover from his near syncope, and we got him a bit further down to a fire road access point. By this time, the hematoma had actually continued to grow in size, and the pain that he was experiencing was, he described it as 20 out of 10. So he was reassessed, and we had strongly recommended that he actually did need to go to Royal Hobart Hospital for monitoring, as we suspected that he may develop compartment syndrome. He was taken down by the pro patroller, and that was also recommended to him. And luckily, as a 21-year-old, he did actually listen, and he went to the Royal Hobart Hospital where they kept him for the weekend to monitor him for compartment syndrome. And then he had surgery a week later to evacuate the blood clots. There's a couple of pictures here. So this is sort of the progression of the hematoma during his time in hospital. So when we saw it, it was literally just started like a rock, and then it just grew and spread, and then it just grew a little bit more. But he was starting to experience significant pain. So here we have, after he'd had the clots evacuated a week later and the bruising to his leg, and then a little bit later, after a few weeks back at home with his mum and dad, the wound had healed, and you can see where his handlebar basically nicely impacted in his leg. Third one. This is a good one. So the triage for this one: 50-year-old male, mountain bike rider, 1.5 metre jump, crashed and hit a tree with an injury to his left flank. Helmet was worn, nil LOC, but with head strike. Significant abdominal pain with a palpable mass. His blood pressure was trending down, heart rate increasing en route. Pale, tachypneic, diaphoretic, 220 mics of IV fentanyl en route. He was given a Cat 1, a trauma call was activated, and he was transferred directly into the resus bay. He had a full primary survey performed and inline C-spine immobilisation maintained. We switched to a Philly collar. He had a second IV inserted. He had a fast performed with evidence of blood. He had his first unit of O negative commenced. Some TXA was also commenced, and the bear hugger was applied to keep him warm. He was log rolled and observed to have a significant abrasion over his flank and his scapula. He then was sent for a CT, who confirmed that he had a large retroperitoneal hematoma with evidence of active bleeding on a phase and a fractured pole of his left kidney. I think they basically described it as he pulverised his kidney. He returned to ED. He then had an IDC inserted, and that started to drain some sluggish frank hematuria. Urology was then requested to come and review the patient, and he was then transferred to theatre. Can anyone feel where this case went bad? The catheter? So just some of the issues with this patient. He actually crashed at Derby. He was an interstate visitor with some mates, so he felt okay after the initial impact. He rode his bike 1.5 kilometres after injuring himself back down to the car. He then started to feel pretty sore and a little bit unwell, and so his mates called Ambulance Tas to come and assess him and take him to LGH. So this transfer took probably approximately 2 hours from the time of the initial accident. And then during the transfer, the patient became hypotensive and symptomatic. And one of the other issues was that post the IDC insertion, the patient became increasingly unstable. He basically had that much blood in his bladder that he was self-splinting, and once he had that IDC inserted, it basically all turned to custard, and he very quickly went to theatre. And I'm not sure of the follow-up on this man, but I do know that he had that kidney removed, spent a time in hospital in Tassie, and then he went back to the mainland. Last one. We've got time? Yep. So the last one, 42-year-old female, triage red, fell off her mountain bike over the handlebars, sustaining a large full-thickness laceration to her bottom lip. Bleeding subsided, nil known drug allergies, nil other injuries. She was given a category 3. She was seen by an ED RMO in our fast track area. They had a brief assessment, was documented and referred to plastics. The patient noted in the notes to deny any loss of consciousness, no neck pain or pain anywhere else. The documented examination showed that she had severe swelling and a massive, almost full thickness laceration across her face, with some facial droop, and there was a huge amount of red dirt stuck in that wound. Her treatment involved having cannula inserted, bloods, she had some IV analgesia, and then later that day she went to theatre where they were going to do a washout and repair of those oral lacerations, and basically she degloved her chin. So while she was in the pre-op area, she actually said to the anaesthetist that her voice just didn't sound right and it started to change. And so the anaesthetist was happy to proceed, but basically with spinal precautions. And then during that induction, it was noted that there was some significant airway edema present. She had a CT of her head and neck performed, and that showed that there was actually a fracture of her hyoid bone and a fracture in the area of her C6. Subsequently, she remained intubated in an ICU for a couple of days, had some IV DEX. She had subsequent CT angio, vertebral brain vessels and MRI, and then she was discharged home and ongoing physio and management of a C-spine injury. Her facial wounds have healed amazingly well, and then she has also returned to riding. So at the start of this case, this lady, her triage is documented that she literally just went over the handlebars from a jump. I did a little bit of digging because I asked her where she'd crashed, and she told me, and I know that there's 3 different jumps that you can actually crash from. Other issues from this was this history provided by the patient was just she crashed on a jump, didn't really elaborate any other details. She was given a Cat 3, which all the staff in ED get their mountain bike trauma education, and most mountain bike injuries are actually a Cat 2. Her facial wounds did provide a significant distracting injury, and that her airway and C-spine issues weren't discovered until she actually was in theatre some hours later. So the next slide is actually a picture of the jump. So if you actually look at the jump and consider how high it is, the story that she gave later was that she was actually following her son, and she didn't realise that he was on the highest of 3 drops. And when she realised what he had basically launched himself off, she braked. So she's braked on the edge and launched herself clean over her front wheel and landed head first in the red dirt. Hence, she actually landed with enough force to fracture her hyoid and the bone in her neck. So just as some questions to ask, if you ever come across a patient who has been in a trauma associated with a mountain bike accident or a mountain bike. So where did you crash? How fast were you travelling? And how high was the jump, or how high was your impact from? What did you crash into? Was it dirt? Was it a tree? Was it a rock? And then what are the obvious and the potential injuries to think about? Because sometimes the obvious injuries are hiding some potential injuries that you might just need to delve a little bit further into to understand. Did you hit your head? Examine the helmet if possible. That will often tell you the degree of impact. When you actually look at someone's helmet, it might actually look okay on the outside. You look at the inside of the shell and it's shattered, or the whole thing is just shattered into a few pieces. And also just to consider with the vital signs, consider what is normal for this patient. A lot of our mountain bike riders that we have, especially in Tasmania, around Australia, are actually elite athletes. So a heart rate of 80 to 100 might actually be quite a significant difference from their normal resting heart rate of 40, which was the case of another friend of mine who had crashed once, who presented with some hematuria and a heart rate of 80, and a doctor actually said, well, he's got a UTI. It's like, well, no, he's actually an elite athlete. He's an Australian champion. He's actually done some pretty serious damage. So just please be curious and just investigate, and have a think about what was the mechanism and what is the potential injury. This photo here is of a jump that has been constructed in the bike park where we work. A little company called Red Bull is about to host an event in Tasmania called Hardline. It's one of the hardest downhill races in the world, and we're lucky enough to be the medical staff. And this is actually one of the jumps. Can anyone see the start and the finish? That's a 90-foot gap in between. So they've just gone through testing this week. So there's cliff drops, there's the 90-foot gap, and there's another bigger jump as well. So the mechanism of injury is quite significant and the stakes are pretty high. So, just always think about how high, how fast, and, is there any other injuries that I might need to look for? This is a picture of my friend Andy up in the air. I was too slow to keep up with the boys on this day. But yeah, should he have actually landed that badly, it was not going to be a good time. And just a final word of thank you. Thank you to everyone for listening to my presentation. Thank you to all of my friends, work colleagues, their children, who've contributed to the footage of this presentation, and also to Em for putting together the video for me. Very much appreciated. Thank you.
Thank you very much, Louisa. And let's have another round of applause for Bridget and Chloe as well. So that draws to a close this evening. I've just checked the updated forecast and even more snow is predicted. It might be a little bit snowy and blowy tomorrow morning, so keep an eye on that. But once it clears, it should be good out there. If Tara Watkis is in the audience, or anyone knows Tara, if you're right, just to come see me, we're just having your email bouncing back when trying to log you into the e-learning. Apart from that, have a great evening, and we'll see you all here tomorrow evening. Cheers.